love to all the doctors and others who laid down their lives in providing care to COVID-19 patients in the country and other parts of the world. Respected Chairperson, Professor Samina Chaudhary, President, Obstetrical Gynecological Society of Bangladesh, President, Endometriosis Society of Bangladesh, Professor Ferdowsi Begum, President SAPO, and elect President OGSB. Honorable Chief Guest, Professor T. Chaudhary, National Advisor, Endometriosis Society of Bangladesh, and he's our great and beloved teacher. You all know him, and he's also already mentioned he's a teacher of teachers. And special guest, Professor Roshanara Begum, Vice President ESB, Professor Lala Juman Banu, National Advisor ESB, Professor Sardar Naim, President Society of Endolaparoscopic Surgeon of Bangladesh, and learned expert speakers. And we have with us Promotesh Das Mohapatra, Founder, Secretary General, Endometriosis Society India, and he's very known to us. We all everybody know him, and he's also very good friend of us for couples of years. And we have with us Associate Professor Michael Cooper, specialist in endometriosis, fertility, and advanced laparoscopic surgery. And a good evening to you, senior, junior colleagues, dear students, and Assalamu alaikum. Endometriosis Society of Bangladesh has been formed in January in this year, and with the objective to provide service and benefit to the patients who are suffering from these diseases, and also education, knowledge, and training to all our followers or all the members of the society, and also maintain honor and dignity of the people practicing this branch of medicine, as well as to help new members to establish their career, and also to create and maintain a spirit of solidarity and unity and cooperation among the members. On 4th March, Society organized a day-long program, including civil society, school teacher, guardian, patients, both adolescent and reproductive age group, to create awareness about disease, sufferings, scope of treatment, and also to understand, need to consider their sufferings during exam, at job place, at home, and in the career development. And we all know endometriosis has a profound negative effect on and reproductive health, including education, career, personal life, and daily activities. Management of endometriosis is still challenged to gynecologists, specifically adolescent endometriosis in adolescents, the treatment, medical or surgical, what and when, and endometriosis with infertility is still a big challenge. And actually, this is a very frustrating condition, not only for patient as well as also for gynecologists. Endometriosis and repeated surgery also is still a dilemma and unsolved issue. So I welcome you all to today's webinar session that can enrich our knowledge and light our skill and scope of the management of endometriosis in this COVID crisis. Thank you. Thank you all.
Thank you, Professor Saleha Begum Chaudhary, Secretary General, Obstetrical and Gynecological Society of Bangladesh, and Secretary General of Endometriosis Society of Bangladesh, for your welcome address. Now we are going for the main scientific core part of today's webinar and web CME. But before going that, I am requesting our teacher of the teachers, Professor T. Chaudhary sir, the honorable chief guest of this session, to give some remark regarding today's scientific arrangement. Please, sir. একটু আনমিউট করে নিতে হবে স্যার। জি ঠিক আছে স্যার, আবার মিউট হয়ে গেছে স্যার, আনমিউট করেন।
ঠিক আছে?
জি স্যার।
So first of all, I would like to thank you all for inviting me in this very important webinar. As a matter of fact, endometriosis is a big problem in any country, and our ideas have changed over the years. Previously, it was thought to be a disease of carrier women, uh, uh, quite advanced in age, but now we know that endometriosis is no respecter of any age. It starts from adolescent, and somebody say even it can start from early childhood and can persist up to menopause, but the effects can also continue even after menopause. So I think this is a disease which has not uh, got the appropriate attention from the gynecologist as it should. And moreover, it has now become apparent that this is not a disease which can be treated by gynecologist alone. It's a multidisciplinary approach is most appropriate for this patient. The treatment is long term. It has got great effect on the quality of life. And I think there are a large number of women who are suffering currently from this disease. Many treatment has been advised, but none is 100% effective and actually is benefit to all patients. So we have to go on discussing about the newer development in the management of this disease. So I'm very glad that this webinar has been arranged today with a sort of getting opinion from not only from our country gynecologists, but also from those who have been working with endometriosis in many other countries. So I welcome our foreign speakers and think I should not take any more time. We should go on with the program. Thank you.
Thank you, sir. Thank you for your nice remark. I am Dr. Sharmin Abbasi, Scientific Secretary of Endometriosis Society of Bangladesh. Now is switch over to our main presentation topic. Our first presenter is Professor Parveen Fatima. Professor Parveen Fatima is the chairman of the governing body of the Care Medical College Hospital. And she is a former chairman of Department of Reproductive Endocrinology and Infertility, Bangabandhu Sheikh Mujib Medical University. And she is the vice president of the Endometriosis Society of Bangladesh, Secretary General Fertility and Sterility Society of Bangladesh, and past Secretary General of Obstetrical and Gynecological Society of Bangladesh. She is the National Project Coordinator, OGSB FIGO PPIOD Project Bangladesh. And Professor Parveen Fatima received postgraduate award in assisted reproduction technique in 2009 from Warwick University, United Kingdom. And she took extensive training on different aspects of assisted reproductive technology in India, Singapore, Japan, Thailand, Denmark, and United Kingdom. And she has about 50 national and international publications. Please welcome Professor Parveen Fatima, and she will talk on situation report of women with endometriosis in this COVID-19 crisis in Southeast Asia. Please welcome Professor Parveen Fatima.
Thank you very much. As you heard, my topic today is situation report of women with endometriosis in this COVID-19 crisis in Southeast Asia. As already Sir has mentioned that it is a disease which creates a lot of problem throughout the whole life of a woman. Even menopause is not giving any relief. So this webinar today that has been arranged, I thanks them to the society to arrange this, and it's a very timely done webinar because these people cannot come to us at this present moment. We are not reaching them, and we are not giving the proper service that is needed for them. They are socially, psychologically very much troubled with this situation. So I'll start my presentation now. Okay, the second slide, this has been already told. The second slide, please. Yes. What is the COVID-19 pandemic in Southeast Asia? COVID-19 is a novel virus, means very new virus, and not enough information exists to us. What it can do to the pregnancy, to a woman with chronic diseases, we don't yet know. But the situation with corona virus is escalating. I'll show you how every day there is a change. On the daily basis, there is a change of the people infected, the people suffering, the death of the people. So those with endometriosis are not considered at risk, increased risks. But initially in April, it was considered this COVID is going to do more harm to the endometriotic patients. But later on, it was thought that no, it is not going to add up any risks with COVID infection, because their defense must be for the virus must be by minimizing social contact and frequent hand washing and isolation. Southeast Asia has hit earliest by the COVID-19 pandemic outside China, but the virus appeared controlled until mid-March. Endometriosis places a heavy burden on women at the prime of their life. So this is the most important time of a woman's life. And infertility history is a risk factor for endometriosis. Incidence of endometriosis is approximately overall in the world is around 10% among the reproductive age group, but it varies in person who are wanting to have, who are suffering from infertility. About 40 to 50% of those infertile women are suffering from endometriosis. And so it is, even it is affecting our adolescent group, as Sir told. It is also in this seed is also in the young group of our women. At the inter-eternal life, the determination of this process starts. So, next slide, please. So about COVID, the COVID confirmed cases as on June 26, 2020, it showed that about Indonesia was the worst hit nation in Southeast Asia, and next to it was Singapore regarding confirmed COVID cases, in exemption of India and Bangladesh. Philippines is the third most affected nation, followed by Malaysia, Thailand, Vietnam, Myanmar, Brunei, Cambodia, and others. So this was the scenario among this group. Next slide, please. And what we have seen in May 18, Indonesia was the, can't see why. Philippines had the highest number of infected cases, and Indonesia, that was fourth most populous nation, has the worst fatality rate per positive COVID cases. In Southeast Asia, around 8.4% mortality in their positive cases, which was higher than the 6.9% rate of global death. And Philippines followed it. The mortality rate of Philippines is, as on June 27th, it is 6.6. But this scenario was not in May 18. So with change of time, the things are also changing. The affection in different places is changing. So please, next slide. The COVID-19 pandemic in Southeast Asia region has been named as Black Swan of 2020. And the reporting in 20th of June was like this regarding India, which showed that highest confirmed cases of 5 lakhs. more than 5 lakhs, 5,08,953. Bangladesh has, on 28th of June, Bangladesh had a confirmed case of 1,33,978. Indonesia had 52,812, and Nepal had 12,309. Then comes Sri Lanka and other countries, Maldives, Sri Lanka, and the other places. The death rates was quite high in India. It was 15,685, followed by Indonesia, which had 2,720. Sri Lanka had the death rate among the COVID positive patients about 2,033. And next comes Bangladesh. It is on 28th of June, our death was confirmed in the COVID confirmed cases as 1,695. So please, can you move on to the next slide? As you know about Bangladesh, the first COVID diagnosed case was on 8th of March. On 22nd March, Bangladesh declared a 10-day shutdown effective from 26th March to 4th April and later extended up to 30th of May. As on 29th June 2020, there has been a total of 1,41,801 confirmed cases in the country, with 75,780 recoveries and 1,783 deaths. Every day the things are changing. The modalities also are different. So the on 29th, our death rate was 1,783. Next, please. Some of the areas where, as that of Mirpur area was more affected. So it is so in every region of every country. What about endometriosis and reproductive disorders? Endometriosis may cause significant pain with impact in every aspect of woman's life. The sooner the pelvic pain is addressed, even in the young girls, better is the quality of life. So early detection is also a problem in them, because it takes a long time for confirming that whether the girl or the lady is suffering from endometriosis. A lag period of 7 to 9 years is usually seen. There is no cure for endometriosis. Treatment aims to relieve pain, slow the growth of endometriosis, improve fertility when desired, and prevent the disease from coming back after successful treatment. This is also important because this is not supposed to be cured, and after a surgery, the patient can come back for the second surgery. So this is very vital, that what to do for them. Once diagnosed, patients require long-term care and follow-up to manage the symptoms. Options include surgery, medicine, and fertility treatment. Next slide, please. Globally, endometriosis is among 176 million people are affected, and endometriosis can negatively impact every aspect of life. So, when a patient is infertile, it includes the pregnancy losses also. Their pregnancy loss is also increased during this period. There is chronic and intermittent pain, increased risks of comorbid concerns, and organ dysfunction. Infertility is time sensitive, and prognosis worsens with age. So once the risk of COVID-19 infection is decreasing, all treatment for infertility has to be restarted. We have not reached the downhill. So with this COVID crisis, slowing down is a better option for us, because we don't know what is the impact of COVID infection in the early pregnancies also. Next, please. Endometriosis is characterized by painful symptoms. Symptoms can overlap. Dyspareunia, pelvic pain, and dysmenorrhea affects 34.4% of the women. Pelvic pain and dysmenorrhea affects 25% of the women, and only dysmenorrhea in 12.7%. Dysmenorrhea and dyspareunia in 6.5%, with a similar involvement for only pelvic pain, and pelvic pain and dysmenorrhea in 3.3%, only dysmenorrhea in 0.7%. And the other thing is, side of the thing is that 10.7% of the women diagnosed with endometriosis do not have any pain. So, although there is overlap of so many symptoms, but patients without complaining is also there, with who are diagnosed for other reasons. Next slide, please. Endometriosis is not to be forgotten during global coronavirus infection. As it is a chronic and debilitating disease, attention to the needs of women with endometriosis in the ongoing coronavirus outbreak is the need of the time. So we have to consider these women and take care and do something for them. The physical and psychological distress of women with endometriosis amid the COVID-19 crisis is important to be addressed also, because they are all throughout the life, they are suffering from pain, from other complaints, but along with it, their physical and psychological distress in these women are increasing due to, as they cannot reach us, they cannot get service. So we have to consider and address that also and think about them, about the thing. Economic changes, social restrictions, and fear that COVID-19 may aggravate chronic pain in women with endometriosis, because whenever there is a shortcoming, the pain feeling can increase. So, and also that there is a lot of concern about the economic conditions of the people and restriction to come out, and these are also, and the fear of COVID-19 virus infection can all aggravate to the and increase the feeling of pain in this patient, as they cannot do anything else for their rescue. Elective surgeries are cancelled and consultation service reduced. Women with endometriosis and infertility about the delay to receive service. Definitely, we are not doing any surgery until the time comes. At least we are more concerned with the people who are in acute crisis. Only then we are moving on with the management. Even if all efforts are diverted to COVID-19 management, symptom control and counseling to be offered to help endometriosis patient to cope in this difficult time. Definitely, we will be all our efforts is to manage COVID infection, to control so that people are not infected, and also if the infection occurs, how to overcome that problem and reduce the death incidence is also a big problem for us. And sudden death with cardiovascular accidents, all these are happening. We are losing so many of our people, not only the seniors, also the mid-level people, even the children have been affected with coronavirus mortality. Next slide, please. Southeast Asian ethnicity and moderate to severe endometriosis, which has been published in Journal of Minimally Invasive Gynecology by Williams et al. Recently. This article observed significantly increased rate of moderate to severe endometriosis, stage 3 and 4 in women of East and Southeast Asian ethnicity. That means the diagnosis of the stage 3 and 4 is more common in our Southeast Asian group. Southeast Asians were 8.3 times more likely than Caucasians to have a previous diagnosis of stage 3-4 endometriosis prior to referral. So somehow the Caucasians are not suffering so much with stage 3 and 4. 2.7% times more likely to have a palpable nodule among the Southeast Asian ethnicity. 4.1 times more likely to have an endometrioma on ultrasound. Southeast Asian women reported less pain and better quality of life upon questioning, especially for the stage 1 and stage 2. There is some genetic or some environmental factors for which the first stage 1 and stage 2 is of better quality, but for stage 3, these patients are having aggressive disease, maybe for some genetic and environmental conditions. The difference in incidence between East and Southeast Asian and Caucasian may be due to genetic polymorphism and that are associated with advanced endometriosis. For some reason, the Southeast Asians are having advanced, and genetic and environmental factors are being taken into consideration. Southeast Asians with minimum to mild disease being less likely to seek care, or genetic or environmental differences that increases the risk of more severe disease among them may be the problem, and it adds up with COVID infection because we suffer from stage 3 and stage 4 problems more than the Caucasians. So with coronavirus infection, how we are managing our stage 3 and stage 4 people who are suffering from pain and other symptoms of palpable node and chocolate cyst. Next slide, please. What impact does coronavirus have on endometriosis patient? Can they be at risk of contracting the coronavirus, which was initially thought that maybe because there is dysmorphism of the organ, the coronavirus may cause more problem with them, but that has not been proved later. Women with endometriosis can be reassured that they do not have an increased risk of catching the disease. This is important for us, that at least because of COVID infection, they may be more troubled about their previous diagnosis. So we must reassure them that will not be a thing for them. Majority of endometriosis surgery is classified as non-urgent surgery. Waiting time will likely increase. So this is also important, as we will not go for surgery for them, very quick surgery for them. So their waiting time will be increased, and they has to accept this and wait for better time to come for surgery. Emergency for endo patients, including during this pandemic, are because we know that endometriosis, although very rarely affects lungs, but proportion of endometriosis is implicated in patients' lung also. So those patients who have lung endometriosis, they will have more problem as coronavirus affects respiratory system. So collapsed lung, when there is a collapsed lung, and that time maybe for life-saving reason, toileting or something to be done. Obstructed bowel, if it comes as a feature for obstructed bowel or obstructed ureter or ruptured ovarian cyst, these are the emergencies that we have to tackle even in this COVID crisis. Next slide, please.
70 people first, madam.
Endometriosis to operate or to treat medically. Southeast Asia is home to over a quarter of the world's population. Endometriosis patients suffer from anxiety, aggravated chronic pain because of economic changes, social restrictions, and fear about coronavirus. Women with infertility are worried since treatments are paused due to the pandemic. Patients with endometriosis need integrated physical and psychological care during the COVID-19 pandemic. To cope with this difficult time, symptom control and counseling should be continuously provided. And whether we treat or not, we must be sympathetic for them, and we have, and telemedicine will be a better option for the safety of our staffs, ourselves, and the patients also. Our patient will come, but along with her, there may be, if we allow a lot of people to come, there can be risks of COVID infection spreading. So this has to be taken into, and but whatever we do, we have to, in this difficult time, we have to control their symptom and we have to do the counseling that is needed for them. Next slide, please. Endometriosis, about 30 to 50% of these infertile patients suffers from endometriosis. Both the pathogenesis of endometriosis and its surgical treatment contribute to decreased ovarian reserve. So this is also one of the things that has to be thought out before any surgical management is done. Distorted anatomy of the pelvic structure in endometriosis may inhibit ovum capture and fertilization. The inflammatory environment of the peritoneal fluid adversely affects conception and embryogenesis. Dysregulated progesterone receptors result in progesterone resistance, in which endometrial receptivity with luteal phase dysfunction occurs. So these are all going against the infertility problem, adding infertility problem in endometriosis patient. Surgical procedures are important risk factor in decreasing ovarian reserve. So repeated surgery is forbidden for them until their fertility has been restored. Surgeries could be performed with attention to preserving the ovarian reserve. Consecutive endometriosis surgery do not improve fertility, so that in vitro fertilization should be taken into consideration early. Endometriosis patients who do not become pregnant following the first procedure are candidates for early entry for in vitro fertilization. Ovarian suppression can be tried to prevent the development of endometrioma, a major threat to fertility. So, in timely management of endometrioma may also help to maintain our fertility. Next slide, please. What we should know in managing infertility related to endometriosis. Pelvic anatomy and endometriosis inhibit ovum capture. This has been told in the... Okay, next slide, please. COVID-19 and women's health with endometriosis. What is happening with women infected with COVID-19 and endometriosis? Endometriosis affects more women in Asia than in any other continent in the world. In the Western population, endometriosis is estimated to be 5 to 10% of the population, whereas in Asian women, it is approximately 15% of the women. So, as a whole, endometriosis is more common in our patients. Increasing trend in deep infiltrating endometriosis and bilateral endometrioma from adolescent to menopause is also more in our situation. As we have told that stage 3 and 4 is more common in our patient for some genetic or environmental factors. Cigarette smoking is associated with an increased risk of endometriosis in women with surgically confirmed endometriosis, as well as it has been shown lower BMI addresses endometriosis. Lower BMI in patients with lower BMI, endometriosis is more common, and less the parity, endometriosis, suffering from endometriosis is more common. There is a recent data that has shown milk and milk product consumption of 4 times milk reduces the chance of developing endometriosis. So nutrition is also coming up as a concern for management of endometriosis. With the global outbreak of COVID-19, hospitals canceled surgeries and people are afraid of going to hospital. However, chronic disease still to be managed. Rowan, researchers from Australia pointed out the neglected needs of women with endometriosis during the global COVID-19 pandemic. So this has been neglected throughout the world. So has something to be done. The authors reviewed endometriosis and its linked to infertility as well as the emotional cost that is. Next slide, please.
Mute for an Okay, last slide.
So, what is the challenges during pandemic for patients with endometriosis? COVID-19 in the reproductive disorder, barriers to diagnosis. So, now to have a proper diagnosis, we will be taking more time. Access to hospital is difficult, so that will also create a problem. Delay in imaging. Even if we ask them on please do an ultrasound or an MRI or the other investigations for infertility, that is also going to be delayed because even the hospitals are not maintaining their original times, and the people doing the ultrasounds are not regularly available. So this is also a cause of delay. Seen by doctors not familiar with endometriosis. When they are coming even for the management, they are not getting their familiar doctors, as well as the doctors who are not familiar with endometriosis is trying to give them the service. Delay of laparoscopy, traditional used to confirm diagnosis, which is usually done, but that delay is also going to delay the management for endometriosis. Minimally invasive surgery at the time of COVID-19. There are number of things about it, because the anesthesia that is going to be there, the CO2 that is instilled when they are brought out, whether this is going to spread the infection also in the minimally invasive surgery. We don't want open surgery, no doubt, but this also has to be taken into consideration before you manage them. ART at the time of COVID, whom to do, especially those who are going to lose their time, their age, will not help us to manage them. Impact and the incidence of an international pandemic crisis. Surgical treatment of endometriosis improves pain symptom, but what we'll be doing, embryos derived from endometriotic patients is already reduced, has reduced ability to implant. What is going to happen more, that is also a concern. Appointments by telephone and online and in person seem safe, but every place has to manage that. So at conclusion, endometriosis must still be treated. Clinical diagnosis of endometriosis is reliable. Medical therapy is the first line. Surgery can be delayed with medical treatment. Individualized treatment is important. And why? Not the same disease to everyone. Since menarche to 20 is one group, 20 to 40 is another group, and 40 to menopause is another group. Treatment has to be individualized. So thank you for the time that you have given me to speak. Thank you.
Thank you, Professor Parveen Fatima Madam, for your very informative presentation on situation report of women with pelvic endometriosis in this COVID-19 crisis in Southeast Asia. Though all of we know that this is the rest time for many of us in Bangladesh, but to adjust the time with our international speaker, Dr. Michael Cooper, we need to choose this time for the scientific time for all of us. To make energetic to all of us, just we go through 1 minute musical presentation of society. Dr. Naim, just present the 1 minute presentation of the music.
আমি এখন শুনতে পারবো তুই না
I'm now requesting our special guest, Professor Roshanara Begum Madam, just add some remark regarding the situation report of Southeast Asian women who are suffering with endometriosis, and the suffering is more in this COVID-19 crisis moment. Yes, Madam.
Thanks, Sharmeen Abbasi, and thanks for the music for a gap. Actually, after looking these photographs, I'm just praying for the God, please send those days. We want those days coming back. We can reach those days. Our today's chairperson, Professor Samina Chaudhary, SAFOC President Ferdowsi Begum, our respected chief guest, Professor T. Chaudhary, our special guest, Dr. Naim Sardar and Professor Laila Arjuman Banu. Actually, we are passing a very challenging time for the endometriotic patients in this COVID-19 periods. They suffer a lot, and I think this is a time-demanding topics, and we need some guideline from this discussion. I think I will not comment anything. Actually, you know our sufferings. Professor Fatima laboratory discuss everything, and I think after all the discussions, we'll get some guideline how we'll go with these patients. So thank everybody, our allegiant speakers and all the delegates who are learning, listening these topics. Thank you, everybody.
Thank you, Professor Roshanara Begum Madam. Our next speaker, who is the legend in the field of endometriosis, Dr. Promothesh Das Mahapatra, sir, who is the director of Spectrum Clinic and Endoscopy Research Institute, Kolkata, who is the ex-honorary consultant, Kothari Medical Center, Kolkata, and who is the ex-chairman of All India Coordinating Committee, Royal College of Obstetrician and Gynecologists, London. And he is the regular examiner of MRCOG and FRCS, founder secretary general of Endometriosis Society India, vice president Indian Endoscopy Society. He is the founder president of Medical Education and Research Society of India, and he is the advisor of Journal of Indian Medical Association and life member of International Society of Gynecological Endoscopy. Please welcome Dr. Promothesh Das Mahapatra sir, and Dr. Promothesh Das will talk about the good, the bad, and the ugly of medicines for endo. Because all of we know that there are very much debate. Some women are just want the medical management, but some have the afraid to get the medical management. So he will give us the guideline about the medical management of endometriosis, and want to share the debate of the knowledge of medical management of endometriosis. Please welcome Dr. Promothesh Das Mahapatra.
Hello. Hello.
Yes, we can hear, sir.
You can hear me. Can you see the slides?
Yes, sir.
Okay. Now, the reason I have chosen these topics because I knew that Dr. Fatima Parveen is going to say everything about endometriosis, leaving nothing for us. However, ladies and gentlemen, we know that the medical therapy is very important for this enigmatic disease. And the title I have chosen from the film, The Good, the Bad, the Ugly, where Clint Eastwood played the leading role.
Dr. Mahapatra, can you please make it full screen?
Yeah, is it full screen now?
No, not yet. Yeah,
now you see, endometriosis is a peculiar and unpredictable disease because it depends on so many armors which is created by the disease itself. Like it depends on the distant estrogen production. It also makes its own estrogen. It is also progesterone dependency. It produces MMPs. There is angiogenesis process, immunological local changes, also inflammatory reaction, and of course, the last one, which is very recently discovered, that new nerve endings are being formed around the tissue of endometriosis. So you see that it has protected armor around its source of the disease. So it can protect from any kind of attack from any medicines. Now, what do we need today? We need, and we have to understand that we are using more of a medical therapy for this disease than surgery, because the surgery has tremendous morbidity chances. And I, being a laparoscopic surgeon, I've encountered quite a few times of rectal injury. And so probably we are more switching over to medical therapy. So from stage 2 to stage 4, and we can also use that pre-operative or post-operative and recurrent diseases definitely. What about the stage 1? Stage 1 is usually amicable to treatment by laparoscopic surgery. So that is not indication for medical therapy unless if the surgery fails. Avoid women with infertility or who wishes to try for pregnancy. Many times I see prescription and endometriosis is diagnosed without giving them enough time. The doctors prescribe medicines. We all understand this situation, that medicine actually causes iatrogenic infertility because there will be no ovulation. All the drugs we are using now are responsible for anovulation. So if someone is coming to you with some stage of the disease, you must give enough time for a natural pregnancy, because pregnancy still can be possible naturally in stage 3 and stage 4. Give them a 6 months time if the sperm is okay, and then you can try to treat the patient according to the decision made by the patient and by yourself. Now, who are wishing to try to pregnancy, you should give them enough time. Now, more medicinal therapy than surgery, as I said, it all depends on the physician's experience. what I have noticed in the future, that many endoscopic surgeons prefer to do surgery for any cases of endometriosis. Whereas those who are not endoscopic surgeons, they try to treat the patient by medicines. So that kind of concept should be abolished. We should sit together and decide what is best for the patient. However, so this is actually depends on the patients more and the outcome of the treatment. The idea of this medical therapy is to induce recreation, therapeutic effectiveness to be considered, minimal or no side effects of the drugs, and that will increase the tolerability of the drugs. So, long-term safety, or less side effects or adverse effects should be avoided, but the cost of therapy is also a great concern for us, because many of the drugs which are now available in the market are very costly. So, you have to look after the pockets of the patient. Time on by endometrial cells and biochemical environment. So that is very important. Because it is an estrogen dependent, we have to suppress the ovarian activity. That is why anovulation is the ultimate. So anovulation is there, so infertility will be definitely going to come. Endometrial cells should be killed. At the same time, the biochemical environment around the tissue should also be tackled. Now that leads to reduction of menses and induced atrophy of endometrial implants. Unfortunately, all the medicines we are using have wider range of adverse effects. And as I said earlier, that iatrogenic infertility, but the last point is very important, 100% recurrence. We cannot cure the disease, but we can manage, we can control the progression of the disease temporarily by medical therapy or even by surgery. Because 100% recurrence is the rule after medical therapy. It's going to come back at some point of time. But this is a very last point is very important, that same medicines may not be effective for all the patients. One medicine can be effective to X patients, and the other medicine can be effective, more effective for the Y patients. So you must remember that. So our selection of medical therapy is sort of choosing arbitrarily. And then the other point is to be remembered that the same women at different times may not respond to the same drug. Means you are using danazol, say for example, one patient for 6 months. After 6 months, she reports the same complaint as before the medical therapy. So at that point, these 2 points are very important. Number one, that all women may not respond to one drug, and same women who responded earlier part of the treatment may not respond later on. So these are 2 important informations which I like you to remember. What are the drugs we need to use or we are using? That's it, NSAIDs, oral contraceptive, danazol, progestins, norethindrone, medroxyprogesterone, Dynogest, GnRH analog, ilopride, fuserelin and triptylin, aromatase inhibitors, and sometimes we do combine other drugs also. This combination of drugs is due to with an intention to avoid complications of this drug, the main drug, like oral contraceptive and danazol. Danazol is given to avoid the complications of oral contraceptive. Similarly, aromatase inhibitors is usually given with norethindrone acetate only to reduce the chance of ovarian cyst formation, which is a very known complication of aromatase inhibitors. Dynogest is usually or occasionally added with NETA because of the side effects, and GnRH analog estrogen add-back is also very important if it is used for more than 3 months. So combined drugs can be used in some cases. Now let's go to pain. Effects of pain was studied by survey by World Endometriosis Society, and you see the figure: 65% employment adversely affected, 30% not able to continue same work, 16% unable to work, and 10% reduction of working hours, and 6% claim social benefit. So that means it not only affects the patient, but it also affects the society, the general public, and also the uh, public committees, like like your government. So these are the things which you have to keep in mind. Now, how can we deal with the pain? See, endometriosis pain is everywhere, from head to foot. If you don't believe, I'll show you the statistics. Pain everywhere, not a person to believe. Sometimes patients complain of pain at different sides away from the pelvis. And we don't usually accept the correctness of the complaint. We say, okay, maybe it's all psychological. But sometimes we also believe that it is a disease which is just making up the stories. So with this, we are sometimes unable to make the accuracies. The problem is with the pain that the severity of pain does not always directly correlate with extent of the disease. But dysmenorrhea, CPP, back pain, and leg pain are the commonest one. Migraines, emotional trauma are also can be associated with the disease. I'll show you the next diagram later on. Now, painkillers plus only painkillers is not going to give the full recovery. You have to use the painkillers temporarily, particularly during the period of pain, but the main aim is to treat the endometriosis. The endometriosis can be treated at the same time with painkillers. Painkillers at the early stage can help only to make the patients feel good that I'm not having any dysmenorrhea. But actually, disease will be progressing. It's a progressive disease. So you cannot stop by giving painkillers. Painkillers will temporarily relieve you from the disease. Now, the best painkiller for endometriosis is cyclooxygenase or COX-2 inhibitors. Why? Because we know the cyclooxygenase induces PGE2, PG12, and PGF2, which produces prostaglandins. So prostaglandins is the root cause of pain, and so it should be taken care of by COX-2. Now, what happens when the patient is having pain for a long time? The normal pathway of pain from the pain side to the brain does not follow the normal pathway. So there is an accessory pathway to carry the pain fiber or the pain sensation from the side to the brain. So that pathway cannot be treated by COX-2 inhibitors. So even if you give COX-2 inhibitors, the painkiller is not going to be effective. So how do you manage that? You have to take the help of gabapentin group of medicines. Sorry. With those who are having pain for a long time, you might have to use gabapentin. Now you see that the site of pain in endometriosis, head 31%, lower pelvis 43%, lower back 54%, lower left abdomen 60%, lower right abdomen 63%, and lower mid abdomen 66%. So in the pelvis, and you can see it is also possible to get headache with this disease. What are the drugs we are going to use to tackle this situation? See the oral contraceptives, 75 to 90% improvement claimed by almost 99% gynecologists of the world. Why? Why so? Because it is well tolerated, fewer metabolic and hormonal adverse effects. It relieves dysmenorrhea through ovarian suppression, induces residualization by the progesterone content. It is a cheaper option being used for ages. We are used to use these drugs since 1960s. Works better when given continuously, that one point to be remembered, but periods are regular with cyclical regime. If someone is wanting to have a regular period, you can keep that in a regular cyclical regime. Now, these last 2 points are very important. Until 5 years ago, we all believed this oral contraceptive is a good treatment for this disease. Now, recently, skeptics are raising the question of upstaging the estrogen. The estrogen contents of the oral contraceptives, even if it's a 20 microgram dose, still it can stimulate the endometriotic tissue. Then what is happening? Superficially, you think that you are controlling the disease, but actually, you are cutting off the pain fiber. You are actually getting the painless periods. Giving you the impression that you are also uh, treating the patient, but that's the wrong information. Because what happens? Only a few formal studies being done with the proper staging of the disease and the use of contraception. So we call it, is it overrated? The claim by the gynecologist, 75 to 90% improvement is overrated. We do not know the actual scenario. But I have patients where I have noticed a patient who was treated by oral contraceptives, yes, they have got the upstaging of the disease. They said it was well for the past 3 months or 6 months. Then the pain is very severe than I used to have before. So what is happening? Are we upstaging the disease by using oral contraceptives? The research is going on now. The other mode of treatment is the medroxyprogesterone. Now, medroxyprogesterone, this is one of my favorite medicines, but it's both can be given both orally or injectable 150 milligram forms, equally effective as other drugs. It can be given cyclically or continuous doses, cost benefit and easily available. Reduces, how does it work? It reduces MMPs, growth factor, inflammatory reaction, and peripheral estrogens. Now, it also affects the bone mineral density, but in compared to GnRH analog, it is much less. GnRH analog produce about 4% of BMD bone mineral density lower, 4% cases, whereas it is only 1.1% in medroxyprogesterone. So medroxyprogesterone proves to be better than GnRH analog, as long as the bone mineral density is concerned. Now, because it has an obesity effect, which is well accepted for underweight women. Now, the main problem is the breakthrough bleeding, which is about 40% of women. That is why it is usually not acceptable to all women. Weight gain, fluid retention, depression is another point which should be remembered. But the most important point is the breakthrough bleeding. Breakthrough bleeding is very important to be remembered. Prolonged delay in resumption of ovulation, that is another point to be remembered. Now let's go to danazol. It's a modified androgen, but the anabolic activity is about 6 to 10%. It inhibits mid-cycle FSH and HSH and prevents steroidogenesis in corpus luteum. It might directly act on endometrial cells and implants also, among oldest medical therapies of endometriosis. It was in the market since 1970s, and we once upon a time thought that it is going to be a treatment for endometriosis. But later on, we found that a higher incidence of adverse effects is very important. An androgenic manifestation like oily skin, acne, weight gain, deepening of voice, hirsutism may be intolerable. So the ugly part is the last one, the permanent voice changes. So you got to be careful when you prescribe for singers or would-be singers. I have a patient who was treated for 19 months by giving the drugs, and she was a professional singer. She lost her voice. So she cannot do any professional singing. Now, GnRH agonist, down regulation of gonadotropin receptors in pituitary, that leads to pain relief, but reduces adhesions also. So GnRH agonist has the advantage of reducing adhesion in addition to the efficient relief of pain. There are various delivery systems and depot preparation is available. But look at the BMD here. BMD is affected about 4% of cases, and it gives rise to menopausal symptoms, but that is reversible. Flaring effect, that is another point which needs to be remembered. How can you control flaring effect? Give injection during this mid-luteal phase. But here is a problem. If the patient is by chance pregnant in that month, then the pregnancy will be disturbed. Pre-treatment with progesterone or oral contraceptive for 6 weeks before the injection also helps to reduce the flaring effect. The third one is very important. If you give antagonist along with this agonist for 7 days, then you are less likely to get the flaring effect. Pre and post-operative uses can be an indication, but the pre-operative, if you get the blood loss during surgery is less, but you get extensive fibrosis of the tissue around these endometriotic areas, particularly ovarian cyst. And post-operative use, it does not increase the chance of pregnancy, but it delays the recurrence. Now, this is another point to concern. This is a really ugly situation that the return of ovulation is not before 3 to 9 months. Sometimes we get patient being amenorrheic for 1 year after giving 6 injections. So for infertility patient, it is definitely a very great concern. Long-term use with ADVEC therapy, we have been now using for 5 to 10 years continuously, every month injection with ADVEC therapy of 1 milligram of Evolol or estrogen. Now, the statistics here, you see that all these drugs I discussed so far gives a help of about 40 to 50%, not more than that. What is happening to remaining patients? They are not getting any benefit from any kind of medicines which I have discussed now. So we are looking for different types of medicines now. The number one is aromatase inhibitors. It is third generation letrozole or anastrozole. It inhibits aromatase enzymes, which is the in thing inside the endometrial tissue and produces estrogen. So aromatase inhibitors directly acts on the endometrial tissue, and which is present in brain, ovary, and adipose tissue. It is well tolerated. Daily dose for years can be used. Acts well on deep infiltrating endometriosis, but by the vaginal pessary. Unfortunately, the pessary is not available in Asian countries. No action on ureteric endometriosis. That is another point to be remembered. Does not reduce adhesion. This is the disadvantage. Wide safety margin, no estrogen flare, no drug interaction. No estrogen flare like your generation. Relatively inexpensive. Adverse effects, GI symptoms, aphalgia, bone loss, severe migraine, and multiple pregnancy. So these are various side effects which can be encountered if you are using that for a long period. We have about 20% of our patients are receiving aromatase inhibitors along with norethistone acetate to reduce the chance of ovarian cyst formation. But if you are using this drug, you should not forget the use of vitamin D and calcium in high doses, especially if you are using for more than 6 months. Then we come the latest one, that is Dynogest or Dyne, which I call it the China's dream. It is a 19 non-progesterone 4th generation progestin and moderate inhibition of gonadotropins. That is where the problem lies. Because at the same time there is advantage. Because it is moderately inhibiting gonadotropin, estrogen is not totally depleted from the system. So the patients do not get any menopausal syndrome. But the estrogen is maintained at the lowest physiological level. It modulates MMPs, induces apoptosis of endometrial cells, no systemic androgenic, rather it has anti-androgenic activities, no glucocorticoid or mineralocorticoid activities. It is anti-proliferative, anti-inflammatory, anti-angiogenic. Direct prolonged inhibition of proliferative endometrium. So if you look at this is probably the drug which affects every weapons of endometrial cells. Wherever it is there, it not only works with the minimizing the lowering the dose of estrogen, but also it acts on anti-proliferative, anti-inflammatory reaction, angiogenic reaction, and also it induces the apoptosis of the endometrial cells, and it modulates MMPs. That is why it is getting more popular. It is almost a safe drug because if you are using 2 milligram, 3 milligram, 4 milligram doses, there is no dose toxicity or genotoxicity. no carcinogenic potential, no toxicity to the production. But this is a very important rapid return of ovulation. If you're treating a patient who is wishing to be pregnant, you give these drugs for 6 months, the ovulation is expected within 1 to 40 days after stoppage of the drug. That is very important information. Satisfaction is 89% and 98% compliance, which I usually do not agree. Cyst size, if you have an endometrioma, it can increase, it can be reduced by 25% to 85% cases. It definitely improves the quality of life. And if you see in our statistics, only for 30 months duration, we have seen by using this in about 169 patients out of 254 patients who we started, and 169 patients stick to the medicines. And we can see that how the dysmenorrhea, CPP, and dyspareunia and spotting diminished gradually, and the amenorrhea incidence increased. Now, this is a very important slide. We started giving Danogest for 254 patients. And then 85 patients, like 33%, 1/3 of the patients left out after 12 months, means after 1 year. And why they've left out, we inquired about these complications. See, the spotting is 18% cases. Cost was hindrance to the use of this drug is about 10% cases. It did not work about 9% cases. And in 7.8% cases, weight gain was the problem, so the medicines was stopped. GI symptoms were 5.9%. CNS symptoms was around 2%. Now here I must mention one thing, that not only depression, one of my patients developed tendency to commit suicide. And then I got really worried about it. And they wanted to consult a psychologist. And they went to the psychotherapist and said, no. Let us stop the medicine first and see what happens. After 7 days, she gradually returned to the normal life. So these drugs definitely causes CNS symptoms. And if you get any patient complaining of severe migraine or suicidal tendency, you must withdraw the drug very quickly. That is very important. Now, what is the effects of COVID-19 in my practice? Because I tend to see many cases of endometriosis. Is in the month of June, last month, we had done video consultation. Unfortunately, my patients group from very poor villages to the very affluent group. So those who had access to internet, I could manage to do the video consultation in 128 patients. Out of that, 58 patients were of endometriosis, and 11 cases were new. We had to cancel surgery for 8 cases. Medication discontinued for supplies problem in 4 cases. 4 patients could not continue the medicines because the medicines was not available or the supply chain was broken because of the lockdown. Now, this is an interesting point. 5 of the patients were scared to have intercourse, only to catch the COVID-19 infection from their husband, who are actually attending office, although 3 times a day, 3 times a week, they were scared to have intercourse. They said, sir, is there any chance of me getting the infection from the sexual intercourse? Well, of course, the breathing and face-to-face connection will be always there during intercourse. So I had no answer. I said, if you must test your husband before you try for pregnancy. We had to defer 2 cases of embryo transfer, and COVID, one of my patients out of this 128, 1 patient actually got COVID-19 infection. So that patient was supposed to have a Zuradex injection, the last one, the 6th one, but I advised her to take care of this person who is going to give injection, and also she is waiting for the final report of the COVID test after 2 weeks. Now, so my idea is to give you an elaboration of the facts of the drugs, advantages, their good side of the story, their bad side of the story, and their ugly story, like tendency to suicide. Now, ladies and gentlemen, I have taken this title from this music called film all the good, the bad.
Et puis, ce sera un grand plaisir pour nos oreilles.
Allons-y pour un petit premier extrait de Kuro Savoy.
and the ugly of the film and it is noteworthy. Deep low. Title song is being whistled by the person here.
Et puis,
Ladies and gentlemen, I take this opportunity to thank you for your participation here. And this is the beautiful sun rising at the Padma River. You can see that. And this is well called all the gynecologists of Sonar Bangla. It's my heartfelt thanks to all of you. And I also thank Innovative Society of Bangladesh. And also I should not forget Mr. Manurul Islam, the Ranata chief, who organized this difficult program for us. And also Saim Siddiqui, the person who actually was looking after the webinar. Thank you very much. And let's hope that we'll have a good time in future.
Thank you. Thank you, Dr. Promothos Das Mahapatra, for your excellent presentation. And I want to make congratulations to you from all the gynecologists of this Sonar Bangla. And last of all, your music will make us some color, give us some dream and vibes in our mind in this COVID-19 pandemic crisis. Thank you, sir, for your nice presentation.
Thank you.
Thank you. May I now request Professor Laila Arjuman Banu, please add some remark regarding the presentation of the Dr. Promothos Das Mahapatra, and also give small remark about the special guest remark of this session. Professor Laila Arjumandar.
Tell about some surgical interference of the disease. But after Dr. Mahapatra, our very, very dearest friend, he has presented this topic very nicely, especially very clearly. Which medicine is doing what it is and when we have to use the medicine. So there are many options for medical medicines in endometriosis. As we know that there is no definite cause of endometriosis, so there are many treatments. When there is a single cause, the definite cause, then the treatment will be single. So I think he has enlightened the subject and enlightened the medical management. So I have just want to know that there is a new drug called elagolix. Do you want to have some light on this medicine, Mahapatra? Elagolix, the generic elagolix. They are telling that this is the most definite treatment nowadays, and it is very popular and effective.
Sir, unmute.
Dr. Mahapatra, you need to unmute, please. Yeah, thank you.
Can you hear me? There are
Hi.
3 reasons. I cannot give any comment. Number 1, it is not available in our country. In fact, it is probably not available outside the USA. And secondly, it is very, very costly. And thirdly, I have no personal experience.
Thank you.
So there are many drugs in the market. This is all in trial and error method being followed. We have to wait and see.
What is the medicine actually? Is it a GnRH antagonist? I think so.
Sorry?
Is it the GnRH antagonist, the elagolix?
Yes. It's a GnRH antagonist.
Yeah. And they are telling that it works excellently. I don't know. Actually, we have no idea at all. So thank you very much for your presentation. I think our colleagues and junior colleagues, they will be much benefited with the presentation, especially the songs.
Thank you. Thank you, Professor Laila Arjumandar, madam. Now it's the time for the presentation of our last speaker. Our last speaker from Australia, Dr. Michael Cooper. Dr. Michael Cooper is a head of gynecology at Royal Prince Alfred Hospital. He graduated from the University of the Sydney, and he spent extensive time training in endoscopic surgery in Europe, United Kingdom, and America. He initiated one of the early endoscopic training center for gynecologists in Australia and is regularly involved in workshops to train other doctors and students. He was previously a board member of the Australian Dr. Rokia, yes, and Gynecological Endoscopic Society of the International Society for Gynecological Endoscopy, and he has been an advisor to the World Health Organization on research and training in gynecological endoscopic surgery. He received an Order of Australia Medal, OAM, in 2018 for service to gynecologists. And Dr. Cooper has been the author of over 50 articles and book chapters published both in Australia and internationally, and has spoken widely within Australia and overseas. He has been an invited surgeon to many hospitals in Australia and Asia, and currently operates in Hong Kong on an occasional basis. And his major interest is in the treatment of endometriosis, particularly requiring advanced surgical and or assisted conception training, IVF. And he has recently started using the Da Vinci robot for many of these cases. Please welcome Dr. Michael Cooper. And Dr. Michael Cooper will talk on surgery for endometriosis in this COVID-19 crisis, do's and don'ts. Please welcome Dr. Michael Cooper.
Thank you very much for the introduction. And I've got to say, Prometheus, it's a hard act to follow. That song just then, it was fabulous. I really enjoyed it. But let me see if I can get started here. Here we are. Okay, we all good? Have you got me on the screen there?
Yes.
Yeah, okay. So, surgery for endometriosis during this current crisis. What I'll do, and I'm sort of cognizant of the time, is I'll just review sort of what's happened in Australia over the last few months, talk about our hospital and what's happening there, talk about some of the mitigation strategies that have been suggested from Australia and the US, and then I guess talk about what might be the new normal, and then finish off with some issues about endometriosis, the complexity, and some things. Some of those points have been touched upon by others, but I'll just run through that. And if we've got time, I'll run a few videos at the end. Australia's been very much like the rest of the world. We locked down fairly sort of early, and the beach up the top scene up the top left there was in sort of late February, and not long after that, March, when it really sort of hit, the country went really into lockdown, and it was extraordinary. So that there was nobody in the streets, the beaches were empty. On one occasion, I rode my bike, and that's a view of the Opera House, which normally would have had people everywhere, but it was completely empty. And as a consequence of those measures, we really sort of flattened the curve, and Australia, as of I think just recently, has had 104 deaths. The infection rate and new cases until the last week or so had been running around sort of 2, 3, 7 to 10, most of them coming from people overseas. So at this stage, we've avoided a lot of the sort of the issues that you're experiencing in your countries. It has had an impact on our hospitals, such that a number of the hospitals were prepared for sort of COVID emergencies and things. And my main hospital, Prince Alfred, was converted to a COVID hospital, and they're seeing a lot of patients who've got sort of suspected COVID, but really the resource was sort of sitting fairly idle, and most of the hospital had nothing happen. So we were in a sort of a strange situation where we were unable to operate sort of at all, and then we really didn't know what to do with people who would have came through who had exposure to COVID. I guess the way I think about this sort of issue is that there was a paper came out online, updated in June in the Lancet, and it was notable that of about 1,100 patients who had surgery, who subsequently were confirmed as having SARS-CoV-2 infection in the perioperative period, including both people who were known to be infected before the procedure and people who became positive in the period after the procedure. There's this massive mortality rate of getting towards 25%. That's sort of pretty concerning. I guess a lot of the people we see with endometriosis are young. They're predominantly sort of low risk, and you would expect they're going to be okay. But nevertheless, there's evidence coming from around the world that this virus is creating lots of other problems other than just respiratory issues. So there's issues with blood, neurological things, kidney shutdowns, and so I don't think we really know what that sort of means. As a consequence, various institutions and organisations have proffered different ideas as to what we should be doing, and I note that in the Journal of Minimal Invasive Gynecology from the AAGL, just in the most recent edition, has two editorial pieces. On one side saying that, look, it's probably safe that we can continue to do laparoscopy, and that if we use air filters and things, we'll be okay. And in the same journal, an opposing view that at this stage we don't really know sufficient about this, that we should avoid surgery, and if we do surgery, it should predominantly be open surgery. So I don't think that anybody really knows the answer to that. My thoughts are that we probably all need to look at this from, I guess, each point of view from the different geographical regions, and clearly all of your listeners and the people on this webinar will have very, very different experiences depending on their sort of local effects. And I suppose that's becomes crucial then in assessing how you're going to manage these poor patients who, unfortunately, for all the reasons that we've been talking about, they have been pushed sort of down the line. They're looked at as non-sort of urgent. And as everyone has said, they're sort of suffering. And in the meantime, time is passing and their fertility status is becoming an issue. So these are the sort of things that you need to sort of work out. You know, is the COVID situation under control? What's the status of the patient? Can you test? And I presume that in many parts of Bangladesh and India, testing is actually probably not possible. And even in Australia, it's been difficult to run things, although we are ramping up tests, and there's a big undertaking in Victoria at the moment. You need to look at your patient population. Can your patient self-isolate before surgery? So we're sort of suggesting people try and do that. That may not be appropriate for lots of people. Can the surgery be delayed? And if so, what sort of alternative strategies can we run? Medical therapy. Prometheus spoke about quite a few of those options and those drugs, and I think there is a place for many of those things. There's also the prospect of thinking about strategies such as oocyte freezing for individuals who may have sort of fertility issues. If time's going to be an extensive period. And then there's the whole issue of adequate personal protective equipment, gowns, masks, gloves. I'm aware that throughout the world there's been a mad race to try and maintain an adequate supply, and in many countries that's been a major problem. And if you can't maintain those supplies, then that means your doctors and surgeons will be at risk and potentially perish. So that's a consideration also. These are the suggestions from our local Australian Gynecological Endoscopy Society. So the aim would be to try and test as much as possible, look at preoperative quarantine, as I've indicated, non-surgical methods, avoiding operating if we can, consider the role of open surgery, and then try and decrease the time in the operating theatres and limit gas. From an intraoperative point of view, Australia's been lucky. We haven't had a big surge of cases, and there was shortages of equipment, masks and things, but my understanding at the moment is that in a large measure that's under control. I guess we wait to see what happens if we get hit by a second wave. It's been suggested to us, at least, and we've all been trained, that the most risky period of procedures is during intubation and extubation. And so we've been advised that we should try and exit the operating theatres at those sort of times to try and avoid exposure to aerosol. Double valve ports, when you're putting your trocars in and out, close them before moving things to decrease that risk of aerosol. Don't direct vent ports externally. Use smoke evacuation systems, and beware of sort of the high risk of explosive type dispersion when you're removing specimens, abdomen and vagina, for that matter. And then at times to use things like plastic sheets over ports, and I've seen hoods over the patient as they're being intubated. And they're all sort of ideas that I don't know that everybody really knows. There are online suggestions. So from the US, they have these resources for smoke and gas evacuation, and what type of sort of systems you should be using. As I've said, you want to use low pressures as much as possible, suction systems, be wary with specimen retrieval, try and avoid electrosurgical plume. If you can, the suggestion would be to have a negative pressure operating theatre, but that's difficult, and I presume in many of your countries that won't be possible. We've sort of moved beyond the first phase of COVID, in that for many parts of Australia, the hospitals have opened back up to try and get to almost full capacity again. the concern about the resources being loaded has been probably overdone, but it was very difficult to pick which way it was going to go. And so now we've reached a stage where, having been shut down for about 3-4 months, we're now starting to open up again, and that's created a number of its own issues. Specifically things such as patient prioritisation, because there's been sort of large queues of people who've been waiting for surgery, and who do you prioritise? I think, as was mentioned before, people with significant things, bowel obstructions, ureteric obstructions, large endometriomas, those type of things, they should probably go first. And pain is a very subjective deal, so it's very difficult to determine who you should run first on the basis of that. We've been using lots of telephone, video sort of health links and trying to talk and engage with our patients without seeing them, face to face. And that's been largely pretty effective. And the Australian government has in fact changed many things to enable that. So there's been really a massive change in our health system in the last few months as a consequence of COVID, allowing a lot of these technologies which have become very useful. As I've indicated, COVID-19 testing, we've tried to use that a lot. It's, the same again as others have said, patients are particularly vulnerable and they're scared during this time. They've had relatives, family who've had issues, who've been involved, who've been in quarantine, and not so much in Australia, but certainly many other parts of the world, deaths have been a real issue. So, they're concerned about coming back to theatre. I want to just touch on a couple of things which I think are pertinent for us as surgeons, and also in terms of attempting to train our trainees. And that is, what we're seeing is that the first cases that are going to come back to the operating theatres are likely to be complex and difficult. That's a problem if you haven't been operating for a while, as I get to in a minute. However, it sort of does open up new opportunities, and sort of, I guess it's an opportunity for all of us to reflect on our surgical practices, our clinical practices, and possibly look at new ways of engaging with our patients, both from a communication perspective with video conferencing and the like, but also looking at new techniques such as robotics. And we've just started using robotics, and I found it incredibly useful. We're up to about a case 100. And we sort of stopped for a while with the COVID situation, but from an endometriosis point of view, it strikes me that the dissecting capacity of the robot is fabulous for the treatment of endometriosis. So surgical skill degradation is a real issue if you're not operating, and if you haven't operated for 3 to 4 months, you may want to consider simulators and the like. And certainly for our trainees, that's a big deal as well, because they're even further limited in their sort of, skill set, and to then stop training for a number of months, it becomes a big issue. I thought I'd just move on, from that point, after really talking about COVID, to then just talking a few bits and pieces about endometriosis and our sort of surgical techniques. So, as I've sort of said, I won't show too many videos from a robotic point of view, but this is a robot shot that we did a few days ago of someone with an obstructed left ureter. In fact, I didn't realise at the time that because the imaging hadn't sort of predicted it, but here you can see, quite an obstructed sort of cul-de-sac. As we start to dissect it out, you can see on the bottom left here, the ureter, the area of compression is for almost universally for these cases at the level of the uterine artery as it crosses. And it's usually only a fairly small sort of band. So if you can deal with that nodular disease and remove it, then you can get around the obstruction without needing reimplantation. So here's our post view on the bottom right, where the ureter is starting to expand out again. We put a stent through just to keep that intact, but that was fine. I'll just move on, and I think also others have touched upon this, but there's a few issues that I think are worth talking about in terms of the way we manage endometriosis. And I really think that we have a major problem because of the way that we've defined the disease. So the definition currently relates to the presence of endometrial glands and stroma outside the uterus. But we all know there's multiple other abnormalities that we don't talk about, and we can't really measure or image or scan that are abnormal in these people. So notably in our lab a couple of years ago, we demonstrated that you could determine abnormalities within the utopic endometrium that would give us a sense of whether somebody had endometriosis. Unfortunately, the histology is very difficult to do. So as a test, it never really became commercially available. But nevertheless, it just demonstrates that really there's lots of problems with this disease, and that simply looking at surgery as a solution I don't think is the answer. And that leads us up a sort of a rabbit hole that makes it difficult for both our patients to understand and for us to manage. So if you say to most patients, look, endometriosis is just an area of disease outside the uterus, well, their response will be, well, why don't you just remove it? And if we just remove it, we're still left with problems. So I'm pretty convinced that surgery alone is not the solution. I think it's surgery plus some other medical sort of therapy, a progestogen or pregnancy or an agent that sort of mimics pregnancy. Moving on to some of the other issues with endometriosis, certainly from our perspective in Australia, I'm sure it's the same everywhere, there's major staging problems. So what is severe disease to one individual may be quite different disease to another individual. There's a very, very significant bias in terms of the skill of the surgeon who's doing the operating. And that then leads to, soft endpoints and problems with you looking at data sets, for example, from a fertility perspective. It's reasonable to say that, you shouldn't do multiple surgeries, and after one surgery, then that individual should have IVF. But if the patient has significant endometriosis that's not anticipated, recognized or resected, then that patient is really no better. So I think it's very hard to sort of generalize about that. And we need some method of being able to work through all these sort of issues. It's quite clear that if you really want to do a lot of this sort of surgery at a high end, you need multiple skill sets. You need specialist teams with both colorectal, urological sort of input. And I do believe that moving forward, we're going to see changes with things like robotics. The cost is going to plummet. They're coming off patent now. And I think, the next few years are going to be pretty exciting in terms of what we will be able to do from a surgical perspective. The robots, it's still difficult in the sense that when you look at this, the robots have got minimal haptic feedback. You can get some visual haptic feedback, but it remains surprisingly easy to undiagnose substantial disease, and that's a big problem when we're managing this from a surgical perspective. I think there's some issues around the surgeon's capacity to understand the disease, in the sense that if you've only seen disease ablated or left, then you don't really understand the extent of the disease. And until you've seen sort of big dissections, it's hard to really appreciate what this disease actually does. And I want to labour this point for a minute here, but here on the top right is a normal uterus that's anteverted. We have a uterine manipulator in the uterus. You can clearly see the body of the uterus, the cervix, and there's a metal probe within the vagina which is angled forward so that we can antevert the uterus. And that gives us that instrument. Well, there's multiple versions of that instrument. We use a Valchev classically, but there's many others that you can use. But you really need that view to be able to do adequate endometriosis surgery. So on the top left, we have a patient with an obliterated cul-de-sac. So the rectosigmoid is densely adherent to the posterior aspect of the uterus. And once we've operated and removed everything in the bottom right area here, you can clearly see the angled area of the manipulator within the vagina. You can see the rectal sort of tube, and that's sort of clean, and we've removed all that sort of disease. Now, that compares to this image where this patient I saw, and she came back to see me and showed me this bottom view. And the preoperative initial view was the photo on the left, where the bowel's sort of stuck, the ovaries are stuck. And again, going back to that normal view. So this, the operator has dissected out both ureters, has reflected the ovaries laterally, but you can't see the cervix, you still can't see the top of the vagina, and the disease is still there. So that all that's happened is that we've now converted what was a difficult operation into a much, much, much more difficult operation. And that's a problem, I think, that we need to be starting to talk about, because the surgeons who operated thought that they'd removed the disease, but they clearly didn't understand the pathophysiology of what happens. We've got a couple of minutes, so I'll just run a few videos. So top left here is a patient who had a nodule within the vagina, and we're going to excise that sort of nodule laparoscopically. Excuse me. So we've just reflected the rectosigmoid away there, and we've gone through the middle of the mass at this point. So ideally we'd do it sort of on block, but on this occasion, because once you get into the vagina, you need the access to see where you're going. So we've taken that peritoneal end, and now we're down to the vagina. So we've got an instrument, a Rampel's forceps in the vagina. We've removed, and you can clearly see the vaginal sort of nodule there. And then we want to get a sort of a reasonable wide area around it. And then we'll oversew it with, in this case, we're using a V-lock, and we lock it, and there's our sort of finished sort of position. Here's, oops, I've got two running at once. So, oops, sorry, let me just go back a bit. So the video on the right is a nodule in the bladder, and we're just going to, it's a similar sort of principle, just wide excision, identify the anatomical structures. We're going to get into the bladder about here, there we go, and we've cystoscoped this patient before, so we know that the area is away from the ureteric orifices.
Hello.
Sorry, yeah. Hello? Hello?
Yes, you continue, please.
Yeah. So we've just repaired that with a PDS suture, and up the top there I've made a releasing incision just to allow a bit more access. Here's this bottom left case is a bowel, like a disc excision of the anterior rectum. So this patient, don't know why that started. Anyway, I'll just let that one go for a second. So if you, I'm not sure if I can stop that. Yeah. Apologies for the technical issues. maybe if I just do it that way. So that's, so the principle is pretty much the same. So even though these cases look sort of different, broadly, they're all pretty much exactly the same. So the principle is to identify the ureters, and you just keep going as high as the pelvis as you need to, and into the abdomen to trace them down, isolate those, move those laterally, and then at that stage approach the rectosigmoid, which is going to be stuck to some varying degree. If you can approach it laterally, that's a better way to go, and you can get into the pararectal spaces and then isolate the area. So we try and leave all the disease, again, on block, sitting on top of the rectosigmoid, and then we shave that area and assess the rectum to work out whether we need to remove an area of rectum or what we need to do. And at that point, it depends who's around and what the assessment is, but we often get bowel surgeons involved at that point. So they come in as a sequential operator. So instead of operating in parallel, we do all this dissection ourselves. And here we see we're putting a bowel probe in, and there's an area on the anterior rectum that's a problem. So we're going to put a stitch in that area and then use a transanal stapling gun to perform a disc excision of that anterior rectum. Most of the patients we see, we can get away with either shaving them or doing this sort of procedure. And we end up with about a 50-cent sized piece of about a 4 centimetre disc after we've done this. But most of our patients, we can get away with either shaving or this sort of procedure as distinct from a segmental resection. And that gives a lot better ongoing sort of morbidity. So the segmental resections are associated with a significant sort of problem. And finally, so the bottom left is another hydroureter that, again, we found incidentally, and so it's the same issue. We're going to dissect down, take out the left uterine artery remnant. So this was following a hysterectomy, and you can sort of see we're coming into the area where the obstruction is, and it's a matter of dealing with that sort of nodule that's invariably in that sort of area, and then carefully dissecting the ureter out of the way. So you can see we're just pushing the ureter to the right, and we've got our nodule of endometriosis on the left. These are difficult because, as I say, they're invariably involving the uterine artery is where the problem is. And as I said, for the vast majority of them, you don't need to reimplant. You can just dissect it out. And once you're through that area, so we're just about to be through that sort of area now, and then the ureter is sort of released. It's probably safer to put a stent in, a double J stent, for perhaps a couple of weeks, which is what we would also have done here. And here we are. So now we're at the bottom end of that sort of nodule. You can see the tissue starting to change shape. It's much more pliable, and there we go. All right. Look, many thanks for the opportunity to meet you all and to be able to share some of our experience with you. I appreciate that, you're having a very tough time up where you are, as distinct from where, luckily we are at the moment in Australia. So good luck, stay safe, and as they're saying over here, wash your hands, and good luck, and hopefully we can meet up in person at some stage in the near future.
Thank
you
you.
very much for the opportunity to talk. I've really enjoyed it.
Thank you, Dr. Michael Cooper, for your elaborating and very nice presentation. I am now requesting Professor Sardar Naim, President of Society of Endo-Laparoscopic Surgeons of Bangladesh. Please give your valuable remark regarding Bangladesh is now passing a very tough situation and crisis time for the pandemic COVID-19. So what is the protocol set up by your society? Is it is the time for to do the regular surgery or only for the emergency surgery if the patient needs any laparoscopic intervention? Professor Sardar Naim.
Oh, thank you. Thank you very much. Can you hear me?
Yes.
Dr. Sharmin, you can hear me? Okay. I really thank you very much and thanks the organizers of the Endometriosis Society of Bangladesh. And it's a great privilege to speak among the specialists and the world-renowned surgeons and gynecologists who are working on endometriosis. And well, I have listened all three presentations. They are all very well and very good and very informative. Specifically, if I speak about the surgery, as you know, we are in Bangladesh, we are not yet have reached the peak probably. And unfortunately, we are, thinking that we might reach the peak any moment, but still it seems quite a bit difficult to predict the situation. But at this situation, what we really need to do is very important to consider the safety of the patient as well as the surgical team. And as you asked me clearly whether we should go for any routine surgery or not, specifically, I can tell you clearly that the time here in Bangladesh is not at all suitable for going for any routine surgery at the moment. We will need only to deal with the emergency cases. And of course, we'll have to think about other factors here, especially the testing factors. Michael has really covered everything. And if we go for testing and then if we really need to do the surgery, and specifically for endometriosis, if it is possible to delay the surgery, I think motivating the patient over telemedicine, over telephone, over video conferencing is one of the most important things. And, you know, as we know the situation in Bangladesh, negative pressure OT and the smoke evacuation system, though there are some indigenous ways of development, this is smoke evacuation system in different hospitals, but which might not be just as safe as what we really think. So safety is a huge consideration. Minimum number of operation. I'm talking about only emergency. If you really need to go for an emergency surgery, then you'll have to think about keeping your team members as low as possible and not to be present in the operation theater when it is not necessary, especially during intubation and extubation. I see also the anesthesiologists are also in this forum, and there are many things to really know and understand. And smoke evacuation, I told you. And another point is, Michael has really made us aware of not doing surgery for a long time might reduce the surgical skill, and it might hamper the development of surgical skill, which is a big issue now. But again, the robotics and all other things are still a dream-like things in a country like Bangladesh. And of course, our colleague from India also will agree, it's not that easy to get all these things with ease. So at the end of the day, we'll have to wait for a while to see the peak. Let's just be very careful about putting ourselves in risk as well as the patient. So I really thank you very much, everybody. I learned a lot from this session. I thank Michael, Dada from our Calcutta, Mahabatada, and of course Parveen Fatima for a beautiful presentations and a beautiful session. Thank you very
sir.
much. Thank you.
Thank you, sir. Now I'm taking just very short remark from Dr. Kausar Sardar, Head of the Department of Anesthesia and Analgesia in Verdim Hospital. Dr. Kausar Sardar just add, if any emergency surgery during the laparoscopic surgery do you need, then how can we overcome for the health hazards from this crisis moment for the patients and also for the healthcare provider, because we need to maintain the safety for the all.
Okay. Thank you very much, Sharmeen Abbasi, for introducing me. I'm also the Secretary General of Bangladesh Society of Anesthesiologists right now. And thanks a lot, leaders of the Endometriosis Society of Bangladesh, OGSB, and SAFOC, for a nice webinar meeting, and all the faculties here. So, before answering your question, just you see that from very beginning of January 2020, when the COVID-19 hit Wuhan, China, we were following what is happening. The disease was new and spreading velocity was quite high. We became scared on that time and worried about the infection rate and the mortality among the healthcare workers. It's a very crucial issue. We from our society concentrated us to print media, electronic media, and obviously on the scientific research papers. We got 2 months time before hitting Bangladesh on 8 March, first case detected by the IEDC, and the first mortality in 18 March. We fall on a gray zone area regarding the anesthesia and the surgical practice in Bangladesh. What should we do? Initially, we passed a very chaotic time regarding the emergency surgery, cancer surgery, and the routine surgery. By this time, we got some guidelines and the instructions from the WHO and our reference societies like WFSA, that is our World Federation, and the anesthesiology, surgical, and OB-GYN societies of different affected countries like China, UK, US, and other European countries. And the instructions is same for the all societies. For the routine surgery, it is to be discouraged. Cancer surgery can be considerable, but emergency surgery is to be continued. So our position from Bangladesh Society of Anesthesiologists is the same. But my another colleague, Professor Sardar Naim, was saying, when to start elective surgery is a big issue. My personal opinion is to follow the R0. It is the that is the spreading capacity of the COVID virus. When R0 value is less than 1, I think it will be a good time to start the elective surgery. And regarding your questions, open surgery and laparoscopic surgery, what precautions should be taken? If you want to go to laparoscopic surgery, you should take all special precaution to minimize the spread actually. So you have to take all the precaution, like you have to use some HEPA filter. There's a HEPA filter you can use in the port port. Close suction with the HEPA filter. You use the suction. You can use the HEPA filter to minimize the spreading. Minimum burn is important because burn it causes the spreading. Special precaution about the gas leak. You should be cautious about the gas leak by the side of the port. Suction of all gases before evacuation of the specimen. Just when you out the specimen, you have to suck out all the inside gases. And of course, Sardar Naim, what he has said, this negative pressure operation theater is very important. And last of all, just I want to make a comment, or just I want to add, because I am very much interested on the pain. Right, today's topic was the endometriosis. Pain is my chapter actually. So interventional some techniques for your endometrial pain scenario. If you raise your conservative treatment, like the drugs, sometimes it has some side effects, like you can't continue more time NSAID, or other drugs have some side effect. So when the condition is the refractory, and have to decide to go for the surgery. In between time, there are some interventional techniques. Since last 1990s, different institutions, few institutions, they are doing superior hypoplexus block. So initially they give the alcoholic block, but nowadays it has been changed. It has been changed to radio frequency of the superior hypoplexus block. So I think you can add in your treatment plan the superior hypogastric plexus radio frequency. It can be a good option to avoid surgery or delayed surgery, or even after the surgery, if the patient complain again the pain, because you know the surgery sometimes it may not give good result. So on that cases, you can send us to our department. That types of the patient we can start in Bangladesh by this way. Thank you very much for inviting me, and especially Sardar Bongshar মনে হয় যে দুজনকে দেখে দেখে দাওয়াত দেওয়া হয়েছে না?
Thank you very much for your nice. আমরা একেবারে শেষ পর্যায়ে আছি. Just we in the last time moment of this presentation and the session. Only 10 minutes we will take. Just want to give the answers of some question from the audience. Nine, please give the questions, please. Our first question to our teacher, Professor T. Chaudhary, sir. The audience asks this: is endometriosis considered an autoimmune disease? If so, do endo patient need to take extra precaution against COVID-19? Sir, please. Sir, action 9. স্যার আছেন স্যারকে কি দেখা যাচ্ছে? আমি দেখতে পাচ্ছি না।
স্যারকে দেখতে পাচ্ছি না।
আচ্ছা ঠিক আছে ম্যাডাম। তাহলে ডক্টর দাস মহাপাত্র স্যার, would you please answer this question, please sir? Just by short briefing, we want to give the answers of the audience.
Hello.
Yes sir.
Can you hear me?
Yes sir.
Well, it is not an autoimmune disease, although there are some immunity complex which is usually associated with the disease.
Yes,
it is not totally an autoimmune disease. So
do endo
obviously,
patient need any extra precautions, sir?
Yes, of course we have to take some precautions, particularly if it is associated with autoimmune disease. If the endometriotic patient has associated autoimmune disease, then obviously they have to take a special precaution. Otherwise, endometriotic patients with the assumption of being a part of autoimmune disease, any special precaution is not necessary.
Okay, thank you, sir. And another next question also for you, sir. Are patients who have been diagnosed with thoracic endometriosis at a higher risk or severe illness from COVID-19? Next question, 9.
I would think so. Yes, because you know the pulmonary function is also compromised in pulmonary endometriosis. So definitely they will have a higher chance of mortality, and if they ever get this infection, that is an additional problem.
So those who have the endometriosis, now a time to take extra precaution to save them from COVID-19 crisis. Thank you, sir. Next question 9, please. Next question for the Vice President of Obstetrical and Gynecological Society of Bangladesh, Professor Farhana Dewan. One audience asked a question: should women with endo pursue telemedicine appointment while in quarantine or lockdown? Professor Farhana Dewan, madam.
Thank you, Dr. Sharmin. Dear audience, good afternoon to you all. I think telemedicine, many things, among the good sides of learning from COVID-19, we have telemedicine is one of them. We didn't know how to practice telemedicine, but we are doing it nowadays. And during my telemedicine practice, what I have found that the first thing is patient can see us. That is the biggest confidence they have when they see the doctor. Secondly, in a case of endometriosis, we can easily ask them questions, take a detailed history, take keen interest in what she wants to say. then we can advise her what investigations she needs to do. In a second visit, we can again see the investigations. And of course, if there is any issue related to surgery, I can give the treatment. But any issue related to surgery, that can always be taken. Thank you very much.
Thank you, madam, for your concise answer. Next question to Professor Shahanara Chaudhury, madam. Madam, do you please answer this question? In what circumstances should a woman with endo seek emergency care in this COVID-19 crisis? Because we get the answer from Professor Parveen Fatima, madam. Madam told us if rupture of the endometriotic cyst or any bowel adhesion, intestinal obstruction, if the patient needs the emergency treatment, then where should she contact? Because emergency now dangerous for the COVID patient. Professor Shahanara Chaudhury, please.
Thank you very much for wonderful question, and thank you all the speakers and all the panelists. It's a very important question because we are not encountering only the OB obstetric patient, but also some of the gynecological emergency we can also handle during this COVID pandemic, especially ectopic pregnancy. And one is the most important thing we encounter in our department is the severe dysmenorrhea. Sometimes it happens exactly like that. It is a ruptured ovarian cyst. So some patient, last month we had one patient with ruptured chocolate cyst. So we have a laparotomy. We didn't, because it is at the night, we thought that it might be a case of ectopic pregnancy, but after opening, it is a ruptured chocolate cyst. So this is one of the important emergency we feel during this COVID. And you know that during emergency in our setting, we cannot able to get the report of COVID testing. So we have to proceed for our management, waiting for the report, of course. And most important emergency occurs if it is a young adolescent with severe dysmenorrhea.
Madam, one question is, if the patient have any emergency, do you prefer to go to the emergency department or prefer to directly go to the gynae ward or gynae?
Probably in most of the hospital, but in our hospital, any OBGYN emergency come directly to our department, because we have separate emergency for OBGYN patient. They got admission directly from our OBGYN emergency setup. We have separate. There is no connection with the general emergency setup in the hospital, in our hospital.
Thank you, madam. Next question for Professor Rashida Begum, madam. Madam, one patient, Sonia Sharmin, wants to know from you. She went through a hysteroscopy for early adenomyosis in February 2018. After that, she went through 4 times ICSI with no implantation up to February 2020. Now, for the last 4 months, my treatment has stopped. My pelvic pain has worsened during the administration of this one. What I should to do? Professor Rashida Begum. Madam.
She's a case of endometriosis. If she underwent ICSI 4 times, so then there is a definite indication of ICSI. So she again she have to try for ICSI. And right at this moment, as she's suffering from severe pain, we have to give medical treatment, which Mahapatra told. Different source of medical treatment is available. And for this patient, I would like to give GnRH analog, which is much effective. GnRH analog with add-back therapy. And along with GnRH analog, we can use letrozole, because GnRH analog suppress the ovarian portion of estrogen, but it cannot prevent synthesis of extragonadal estrogen. So we can add letrozole along with GnRH analog to suppress the total estrogen and to reduce the endometriotic focus, as well as we can use calcium, because both drugs when suppress estrogen tremendously, then we should give add-back therapy, steroid, vitamin D, etc.
Thank you.
Even then, sometimes we can add some painkiller as well.
But patient wants to know from you, is there any hope 4 time ICSI is failed for this patient?
Definitely, so long egg is available, there is hope.
Thank you, madam.
So long egg is available, yes.
Thank you. Professor Firoza Begum. Madam Atsin, Professor Firoza Begum. Treasurer, Endometriosis Society of Bangladesh. We have only 3 questions left. After that, we will finish. Firoza Begum, madam. Next question, please, Nine.
না থাকলে শেষ করে দাও তুমি।
Next question for Professor Firdausi Begum, President Suffolk, Madam. Is the dioxin, who is the environmental contaminant, are they making endometriosis worsen? Professor Firdausi Begum, Madam.
Thank you. The thing is, first of all, we do not know the etiology of endometriosis. So it's sort of multifactorial. There are many things which are affecting with or without our knowledge. Basically, I should say we know little about endometriosis, as though we are working on over 100 of years on it. So it may affect. So it can, environment has of course a role, we know that. So any environmental factor can affect those. So we have to be aware about, there was, I think Professor Praveen Fatima was telling that good nutrition is coming into now in picture. So also the environmental toxins and this can play a role, though it is not definite, but it can play a role. Thank you so much.
Thank you, Madam. Next question, please. Next question for Professor Saleha Begum Choudhury, Madam. What can women with endo do to boost their immune system and stay healthy during this pandemic situation? Because many of we know that low inflammatory diet help us from endometriosis. Do they help in this lockdown time? Professor Saleha Begum Choudhury. সবাইকে আনমিউট করে দাও নাহলে নাই। Saleha Madam আছে?
Yes, it can help. Actually, it can help. We know this, that actually the COVID-19, this is a disease. It has a lots of it causes, that is a cytochrome storm. It is associated with the cytochrome storm. That is a very severe inflammatory reaction during COVID-19. So in that case, those who are suffering from actually a very severe case of COVID-19 use the anti-inflammatory drug. That is one injection we usually use in severe cases. So diet also can help in this condition. That is what I think actually it is as it is inflammatory and process, so low inflammatory diet is effective. And
can I add? Yes, thank you, Madam. Next question for Dr. Mohapatra Da. One audience asks a question to you. I am 24 years old, unmarried, and COVID positive for 4 days. My period started from today and had severe pain. May I take NSAID or it may risk me for danger? Are there any alternative at home or over-the-counter remedy you would recommend for treating endo-related pain?
So I think best thing is to go for NSAIDs, and then you can use your hot pad application there on the lower abdomen.
A patient want to know, sir, NSAID may cause any risks for the COVID disease?
No, it doesn't. Aspirin is one of the NSAIDs. Aspirin is never stopped for the patients who are having aspirin as a preventive aspect. In elderly patients, they are all allowed to continue aspirin.
Thank you, sir. Next question for Dr. Michael Cooper. Our one audience wants to know from you, what should I do if my surgery has been postponed? Should women with endo consider going back on the pill to help manage the disease while surgery are postponed? My endo surgery postponed for how long? And any age demarcation for the first surgery for endometriosis? Dr. Michael.
So it depends really on the age and the circumstance of the patient. So if you're talking about if it's pain, then definitely the pill is a good idea. Or sort of a GnRH analog. I guess if you're talking about somebody with a fertility issue, then, depending on circumstances, it might be that doing things like, IVF may even be an option if you were sort of umming and ahhing as to which way to go. The answer as to, how long the surgery may be postponed is that's a sort of in English, we would say how long's a piece of string, because you have no idea what's going to happen and things could change, next week or next month. So that's hard to answer that one. And the age demarcation for the first surgery for endometriosis is an interesting question. I think there's several schools of thought. So my own view and experience is that in younger people, if you operate, you may obtain a diagnosis, but not uncommonly the endometriosis is a little bit like a rash, so that there's widespread sort of areas. And it's been my sort of view that the peritoneum we all regard as something sort of solid, a bit like sort of skin. But the reality is it has very vastly different sort of properties. And it's sort of notable that what you see in younger women, of the age of 16, they will have a generalized sort of scattered sort of area that's clearly endometriosis. But as age goes on, those areas tend to coalesce into more sort of focused sort of lesions. And, I don't really know, but I liken it to sometimes, say, oil on sort of water. So if it's out in the middle of the ocean, it can be spread very widely, but then against a sort of a backdrop of a coastline with a wind, it can be sort of concentrated. So I try and avoid surgery for as long as I can, because, as I say, obtaining a diagnosis is not necessarily the major sort of deal, and you're not really doing anything much. If you get to a point where you've got an actual nodule in the area that you can excise, then those people you're going to make an impact on. So you're not really moving the dial in terms of changing the dynamics for that particular patient. So my inclination is to try and put them off.
You. Thank you, Dr. Michael. Professor Laila Jubbanu, do you want to add anything? Very shortly. Just unmute, madam. So unmute for an madam.
Actually, in this COVID situation, we postponed many operative cases, especially the laparoscopy cases, when there is no emergency. But in some emergency, like the severe pain due to the ovarian cyst or chronic endometriosis, then we have to do the operations. And in last week, I also have done 2 cases like this. So how long it is not, there is no definite period. But if there is any serious condition, then surgery can be done.
Thank you, madam. Thank you. Professor Shardari Naim, sir, do you want to add anything? How long we postpone? Because already 4 months Bangladesh passed. We are just in the last question, or 1 question left only. Shardari Naim, sir, absent?
Sorry, Sharmin. Can you repeat the question again?
The question from one audience.
Hello?
The question from one audience is how long the endosurgery postponed, because already 4 months we passed for the crisis situation.
Yeah, thank you. Can you hear me?
Yes, sir. Yes.
Hello? Can you hear me?
Yes, sir. We hear you.
Okay, actually, well, it is very difficult to predict now, because you have seen we have done so many projections before that we thought when it was started at the beginning of March, we thought by April it will reach the peak. Then we thought by May it will reach the peak. Now even some people are talking about maybe reaching the peak might come at the mid of September. So it is directly related with the peak and incidences of the cases. Though we all know in this country, the testing facilities are not enough. In a country of this population, this bulk of population, the number of cases we are doing tests and getting positive results, like around 20% every day, it is not enough. So we might need to go for even 100,000 cases testing for a day. But since we are not able to do that, our all projections are getting wrong one after another. This is not from myself. This is even was a comment made by the top people from the government, like Health Ministry and Health Directorate. So it is for me very difficult to say when to reopen the surgery. But hopefully, I think at the end of this year, like September, if the peak reaches in September, then by October, November, we might go for thinking. I mean, we might be thinking to go for routine surgery by the end of this year. So I'm not very optimistic about it. As Michael Cooper also told us that new normal life will have to acquire eventually.
This is
we
very
have
tough
to know, how we can adjust or we can accommodate in the new normal life. If we go for a new normal era or new normal situation, then at the end of this year we might really thinking of going for that. Thank you.
Mohapatra sir, is there any demarcation of the age for the first surgery of endometriosis?
Not at all.
Not at all. Professor Laila
Because we have seen 16 years old girl with 24-week size ovarian cyst of endometrioma.
Okay.
So you can't wait.
There is no age demarcation. This
There's
is
no age demarcation.
Final answer.
If it is necessary, you have to do it. Now we don't do surgery for stage 1 or stage 2 in younger patients. That you understand. But if there is a specific indications like big endometrioma, or the patient is having excruciating pain every month, and none of the medicines are working for her, then we have to go in and see. Now, coming back to this question, what do I do if my surgery has been postponed? I would ask her what type of surgery she is going to have.
Laparoscopic surgery for endometriotic cyst of 10 centimeters.
How big is the cyst?
10 centimeters.
If it is a big cyst, well, I think we should not wait that much. But if it is a less than 5 centimeters, then we can wait. We can put her on Dynogest rather than considering use of pill, because the pill is going to upstage the disease.
Yes. Sir, one audience asks question to you: how long the Dynogest can continue? 6 months, 1 year?
Continue can be 6 months, 6 years.
5 years.
Maximum, We are using for 6 years now.
Next question.
We have patients of more than 100 who are using for 6 years.
Yes, we have just only 2 slides left. Second question for the Professor Firoza Begum, madam. I want to join for Professor Firoza Begum. Professor Firoza Begum. আমি এটা ম্যাডামের জন্য রাখছি। Next question, please. Madam join করবেন বলেছেন. This is a question to Professor Sherin Farah Siddiqa. The patient is depressed, feeling alone and isolated. What can women with endo do to maintain good mental health during this crisis moment? Does antidepressant help in endometriotic pain? Professor Sherin Siddiqa. Professor Sherin Siddiqa. আছেন ম্যাডাম?
আনমিউট করতে হবে,
আনমিউট করেন ম্যাডাম, আমি দেখতে পাচ্ছি না।
সেরিন আগে ছিল, এখন তো
শোনা যাচ্ছে?
জি।
দেখা যাচ্ছে?
না,
দেখতে পাবো না, আপনি বলেন।
আচ্ছা, ঠিক আছে। Okay, so the answer to your question is a very nice question. As we know that in endometriosis, pain, and nothing can help actually. We can give this sort of medicine, that sort of medicine, whatever it may be, but I think good counseling is very much essential here. And next, for the medication, we cannot take the oral contraceptives or any sort of hormone because it causes the irregular bleeding, irregular pain, whatever it may be. And we cannot even go for surgery right now if it is not really that much emergency. So I think the proper counseling to the patient, time to time, telemedicine, and we should talk to the patient very nicely, very clearly, because giving the antidepressant is not the answer, I think. Proper good counseling is a very much important issue for her. And along with that, she can have a exercise, yoga, and it will help definitely. And if it doesn't work, in that case, she can take definitely antidepressant for a while, but it is not the actual medication. I think the proper counseling, proper medication, food, diet, nutrition, and time to time intervention. That means we can give her the medication over the telemedicine, and it will be helpful for the patient.
Thank you, madam. Next, we are just previous question 9. Previous question for Professor Firoza Begum. Professor Firoza Begum, madam, one audience asked you, I have endo and I was planning to undergo IVF to get pregnant. Those appointments have been postponed due to lockdown. What can I do to preserve my fertility now this moment? Can IVF and other procedure be done during this crisis moment? Professor Firoza Begum, madam.
Can I give the answer?
Firoza Begum, madam. Madam আসছেন।
Unmute করতে বলো।
Madam unmute করেন। আমি দেখতে পাচ্ছি না, একটু আপনারা হেল্প করেন। Unmute করে নেন Firoza Begum, madam.
Can you hear now?
Yes, madam. Please, madam, give the answer of the audience question, please.
In Bangladesh, our media and most of our IVF drugs are actually imported from outside. So I think none of our specialists who are doing IVF at this moment have started IVF. I do not know. But for this patient, if there is no problem, why she has an endometriosis and she can have OCP, she can have GnRH analog, and to suppress the ovary. So she can do it later on. This is my opinion. And I had a question actually to Michael Cooper, and I don't know whether you have seen it or not.
Yes.
The question was regarding the
Hello, হ্যাঁ শুনতেছি।
Rokya madam ko mute karo, nai.
Madam,
yes, madam. Question to Michael Cooper. Yes.
Question to Michael Cooper.
Yes.
He does lots of surgery. What about the fertility preservation? Or if there is a bilateral endometrioma, big size, and patient wants to preserve her fertility, what will be?
Dr. Michael Cooper, very shortly.
Does he recommend this fertility preservation or not?
Dr. Michael Cooper.
That's an exceedingly difficult situation, and I'm not sure everybody knows where, what we should be doing. What we do is get an anti-Müllerian hormone assay and AMH and get a feeling for the underlying ovarian reserve. For some patients, if the underlying AMH is good, then we will potentially look at doing a cystectomy. If the AMH is very poor, then we'd revert to what I tend to do is drain the cyst laparoscopically, because then I could get an option to have a look at the pelvis and see what it looks like, because a lot of the people with endometriomas will have much more substantial disease and often bowel involvement, so it's good to get that information. So we drain that and then put them potentially through a stimulated cycle and either freeze oocytes if they're young or potentially freeze embryos. I think somebody alluded to it before, but the utopic endometrium of people with endometriosis is abnormal. So during a stimulated cycle, you stimulate the utopic endometrium so that you potentially make that abnormality even worse. So it may well be that the frozen transfers in people with endometriosis is better than the fresh. Anyway, so we're sort of going down that sort of route.
Thank you, Professor Parveen Fatima, madam. Do you want to add anything in here, Professor Parveen Fatima? Professor Lailaji, madam, do you want to hear?
Sharmin,
yes, madam.
Probably I could not tell him properly whether he would like to do some freezing of the oocytes or some ovarian cryopreservation before doing the surgery.
Correct.
Yes. Dr. Mahapatra sir, do you want to add anything in here? Dr. Mahapatra sir?
Yes, I think the question was rational.
Yeah.
We can actually preserve the ovum or the ovarian tissue, but that has to be planned well beforehand. Otherwise, the facilities will not be available in the theater. So if nowadays we are seeing that patients are requesting us whether they can have their egg frozen or the ovarian tissue frozen before the surgery. And so because that becomes an extra burden of money-wise, so we also counsel the patients very well. And if they agree to spend that much of extra money, then we can organize that. We do that.
Thank you, sir. Professor Laila Chumarmanu, do you want to add? Yes, madam.
How much bigger is the cyst? But even then, if we just peeling of the cyst wall, there is some ovarian tissue remains. So if you do it very carefully, then you can preserve some ovarian tissue on both sides.
Thank you, madam.
I think before any decision is taken, we should take the help of a good sonologist. The sonologist can tell us whether there is a viable ovarian tissue surrounding the cyst or not. In fact, they can actually pinpoint number of follicles present there. And from their readings, we can take a decision. That is very important.
Thank you,
Can I
sir.
have a question, please?
Madam, I will come you later. That's the last question. We are in the last question to Dr. Kausar Sardar. Is there any self-management course or pain management program that a patient can develop in home to reduce the pain of endometriosis in this pandemic crisis? Nine to the question to Dakao.
Yes, thank you.
Yes.
Thank you very much. It's a relevant question that has been asked and answered by the Professor Sherin, I think. Yes, we can add some drug, that is the antidepressant. Yes, it will work because you know the endometriosis pain is not only the nociceptive pain. When it's a prolonged than 3 months in duration, it became complex because you know there is a neuroangiogenesis is there. Dr. Cooper, he said rightly, when they have go for the biopsy, they got the nerve tissue in the endometriotic tissue. So there is another component than the nociceptive, that is the neuropathic part. So neuropathic part, to control the neuropathic part, you can give the antidepressants drugs because it will raise, like duloxetine is the very good choice. Duloxetine, this is the SNRI. It will increase the level of the serotonin in the synaptic cleft. And also you can use pregabalin or gabapentin. It's a very good drug for the chronic pain scenario when there is a neuropathic part also, because it acts in the presynaptic level. That is, it prevents the glutamate surge in the synaptic cleft. So it works very well, I think. So you can add these 2 drugs in this COVID situation when the patient is in home.
Thank you very much.
Can I respond it?
Yes.
Okay.
Very shortly.
Yes. Actually, I respond to the previous speaker. Pain is the continuous process for the endometriosis. In that case, if you are using the antidepressant drug, in that case, the patient will be just addicted. So better to avoid the antidepressant drug directly. We can give the neuropathic drug definitely. We are using the gabapentin or pre-GABA. But antidepressant are better to avoid. If you give it, you can give the bromazepam or something like that. But it's not the antidepressant.
Thank you, madam. Thank you, madam. Last question for Professor Gulshanara Begum. Gulshanara madam, will endometriosis come back if I will take as HRT after menopause? Professor Gulshanara Begum.
Thank you, Dr. Sharmin, for this question. Yes, will endometriosis come back take HRT? Sometimes we see that there is history of operation of the chocolate cyst and the total abdominal hysterectomy and given HRT, and patient develop again chocolate cyst. So hormone HRT containing estrogen and estrogen especially, cases the recurrence of endometriosis is possible after giving treatment by HRT. I mean, I have one, and I want to ask one question for Mahapatra.
Yes, madam.
Question: we are missing new cases from diagnosis of endometriosis during this pandemic time. by using telemedicine, is there any new protocol for diagnosis of endometriosis?
Thank you, madam. Dr. Mahapatra, sir, is there any protocol for telemedicine to diagnose endometriosis? Sir.
Oh, you see, endometriosis can be diagnosed
Next slide,
definitely by laparoscopy.
Yes.
Otherwise, we can clinically, from the history and the clinical story or clinical examination, we can more or less 99% be sure that this is suffering from endometriosis. So it is not always necessary to take the help of laparoscopy. By telemedicine, you are asking question. Now, in a question you have to, specific question you have to ask to the patient, not from the mothers or family members. You ask the specific question to the patients, and then you can reasonably be sure whether she is having endometriosis or not. I think one of these speakers said in earlier times that the counseling is very important. You should always take a consent from the patient. And I'm doing telemedicine. I'm listening to you. My diagnosis is from your story. So it is not a 100% reliable diagnosis. That is, so you must take a consent and you must write on a prescription that this is report is according to the video consultation with the patient, not from the physical examination. That is very, very important. Nowadays, if you make a mistake in making diagnosis by video consultation or telemedicine, patient might go to the court that I had breast cancer and doctor said I had nothing. Now I got breast cancer. So you can be sued. It is very important that you should mention specifically on your prescription. This was a telemedicine discussion and it was a provisional diagnosis, not a confirmatory diagnosis.
Thank you. Thank you, Mahapatra sir. Thank you, Professor Gulshan Ara, madam. And this is the last slide. And in this last slide, I want to take comments in one line from the special guest, from the chief guest, and also from the speakers and from the chairperson also. I start from Professor Roshan Ara Begum. Does this pandemic offer any silver lining or benefit in women with endometriosis? Kono benefit ki ache? Je ghore ache, family sathe ache, tate kore ভালো থাকার উপায় আছে কিনা প্রফেসর রওশন আরা বেগম আছেন
Sometimes it helps by counseling with the other family members, but endometric pain is so much severe. Nothing is helping with others, even with the husband's counseling. So some sort of help maybe, but not too much. Okay.
Thank you, madam. Professor Naila Arjuman Banu, any silver lining, madam? Do you see any silver lining?
I agree with Professor Roshan because it is the cause is unknown and the cause is not with the psychiatric. So,
no way, no hope to stay home, but there is no benefit.
I think there is some benefit. Can I say something?
Yes, sir.
Since the husband is staying all the time at the home,
yes, sir,
he can see some of the. He can witness some of the sufferings of our wife.
Yes.
Because if he spends most of 8 hours in the office, he would not realize how the pain is going through in the patient's mind.
But no,
your husband can share some of the sufferings of the women.
Dada, I want to add.
Yes.
One confirmed case of endometriosis suffering from many years and one's children. But in this pandemic situation, I don't know how she conceived. This is a miracle. Maybe relaxation or maybe anything. I don't know. Maybe this is the one of the hope we can say.
Thank you.
One of my patients.
Charmin, can I just add?
Yes, madam. Yes.
Madam. Yeah. Thank you. I think I have 3 points to say here. Firstly, the psychological part will be dealt with. Because she'll be at home, she might even be relaxed because the family is surrounding her. She might even become pregnant, as Saminapa has said. And the third thing is that the mind will be diverted, and that will be a good part. Thank you.
Thank you. Thank you, madam. Dr. Michael, do you see any silver lining or benefit?
Can I add more?
Dr. Michael. Yes, yes. One line.
Michael or Serin?
Michael.
Look, yeah, I mean, there might be some subtle benefits, as Prometheus was saying, in terms of family infrastructure and dynamics, but above and beyond that, I don't think so.
Yeah, thank you. Thank you. Professor Shardar Naim, do you see any benefit?
Well, actually, I'm the listener here, but I think, probably Farhana
Need to stay home, Shardar Naim, sir. Is there any way to avoid surgery?
Staying home and having the husband behind, along with the patient. It is important that husband can understand the pain of the wife who is going through this endometriosis. This is a good thing. But regarding surgery, as you know, it should be delayed, and medical treatment is the treatment of choice at the moment for endometriosis, if it is possible to delay the surgery. Unless and otherwise, it is.
Professor Rashida Begum, do you want to add anything here?
Actually, I wanted to say, which Dada already told, that husband can feel the pain of the wife. He's
Husband can feel the pain, yes.
But if husband is not considerate, then reverse can happen. she may become intolerant to husband. Expression of sorrowness and pain. So both can happen. And we know during Corona period, divorce can happen. That is so
Professor,
both sides.
Do you want to add anything in one line? Yes, same.
Okay. I have so many points. Number one.
1 point, please.
Number one, she's stress-free. Number two, she's taking regular rest. Number three, she can take the proper and the adequate diet. This is again the good for her. Number four, nowadays everybody is telling that take more and more vitamin C. So vitamin C directly can help. And finally, we all are advocating all the patients to have the regular contraception. So those who are taking the regular contraceptives, it is
Thank you, madam, for your nice compliment. Now at the end of the session, I am just taking a remark from Professor Firdausi Begum, madam, President SAPOG.
Thank you so much. Thanks to all the speakers and the organizers, and of course the discussants for this wonderful session. Though a bit longer, but it has covered comprehensively, I think, especially the COVID-related issues. Now, one thing is important. There are several things which are important. I will touch 2 or 3 points. One is, are we collecting data? What we see beautifully, Australia is doing. Dada has, Dr. Mohammadur has presented us as well. So we need to organize and collect the data on endometriosis and see what is happening in this period. And as we know, this is a disease of unknown etiology. So still the treatment and suffering will be going to continue because we don't know enough about this patient. We have to go on. But we are worried about that. Are we losing the skills of surgery? So that's an important issue. Then we should go on this doing webinars and maybe. And finally, the safety of the patient and the doctors. This is above all. Thank you so much.
Thank you, madam. Thank you, Professor Firdausi Begum, madam, President SAPOG, to elaborately describe in nutshell about today's web CME. Thank you, madam. I'm now requesting Professor Samina Chaudhuri, President of Obstetrical and Gynecological Society of Bangladesh and President of Endometriosis Society of Bangladesh, give the last remark of this session. Madam.
This is a wonderful session we had today, and one thing I learned that we need one guideline on endometriosis in this situation. So I think it's our duty to make something on that, and this maybe with support or maybe with the Endometriosis Society of Bangladesh, that can be done. And about presentation of Professor Parveen Fatima, and she had given her excellent presentation on women in crisis situation. She elaborated very nicely, and it's a very good presentation. And Pramod is a very informative presentation, and you have presented in a poetic touch and very enjoyable, and especially the music that whistling is so sweet that we enjoyed it very much, and it's a lovely music. And about Michael, we are very happy that you have managed time to come with us, and your presentation is, I think our juniors will be benefited from your presentation. And for all of us, I think we enjoyed the session, though it is long, but it covers most of the part of this endometriosis. And we need to elevate the pain of the sufferers in this situation. And I am again giving stress on making some guideline on this endometriosis management in COVID crisis. Thank you very much.
Thank you, madam. I am now requesting Professor Zinatara Nasrin to give the closing remark and vote of thanks.
Thank you. So it is my honor or privilege to have proposed for the vote of thanks. Actually, I'm not remarking, I'm just giving the vote of thanks. Everything is done. So it's we have very much grateful to the chief guest, Professor T. Chaudhary sir. Thank you so much for being kind to us. And then, of course, we are very happy to have 3 special guests today in this webinar. That is wonderful. And yes, we are very, very grateful again. And thanks, Professor Roshana Begum, Professor Laila Tuanban, and Professor Sharder Naim. Thank you so much for being with us. And then, of course, we are also lucky to have the 2 presidents, President OGSB, Professor Samina Chaudhary ma'am, and Professor Tulsi Begum. She is the president of CEPHL. And we are really, madam, we are very much grateful to you and thankful for your, heartfelt, relentless work and support to the webinar. And of course, we are very happy, and I have to mention and appreciate all the speakers from the desk. The wonderful their presentation, Professor Parveen Fatima, Professor Promothesh Dashma, and Michael Cooper. Wonderful presentation. Thank you so much, and really, really thoroughly enjoyed the whole session. And of course, I would like to give our heartiest thanks to our our Secretary General, and of course to the co-moderator to conduct this whole session so beautifully. And of course, I have to give thanks to the legend obstetrician and gynecologist who answered very nicely. Finally, to all panelists and the Renata, who is always by side of us and having support for the academic purpose. Thank you so much, everyone.
Thank you, madam. Thank you very much. Thank you. আমাদের টি চৌধুরী স্যার কি আছেন? আমি স্যারকে দেখতে পাচ্ছি না। স্যার কেউ দেখতে পাচ্ছেন? মনে হয় নেই স্যার। ম্যাডাম আছেন স্যার? কেউ দেখতে পাচ্ছেন স্যারকে? পাচ্ছেন?
স্যারকে দেখছি না আমি।
Thank you.
তোমাকে ধন্যবাদ। Many thanks to Sharmin. Excellent anchoring. Thank you very much.
Thank you, Mahapatra sir.
Thank you, Sharmin.
Thank you. Welcome. Parveen Fatima madam, and last of all,
thank you, Sharmin. It was wonderful.
Just last of all,
তোমার effortটা was wonderful.
Thank you.
Promothesh da, ভালো আছেন?
ভালো আছি। কবে দেখা হবে
জানি না, এখন বলাও যাবে না।
আপনি কিন্তু আমাদের এটা কিন্তু শেষ, এই আর রেকর্ড করো না।
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.